So I will move on with my slides. So here are my disclosures. And wanted to emphasize that not all myelofibrosis is the same. Now that we have multiple different JAK inhibitors, we can start to tailor the use of a JAK inhibitor specifically to the MF patient. And although each MF patient is quite unique, we could put them into two general categories. The first category being cytopenic myelofibrosis. Those are the patients with the low blood counts. These are usually primary myelofibrosis. They tend to have a lower JAK2 allele burden and tend to have a poorer prognosis. And on the other end of the spectrum is the myeloproliferative myelofibrosis. These are the MF patients who have very usually robust or elevated blood counts. In general, can commonly be a for example, post-PV myelofibrosis patients, and these patients tend to have a better prognosis. So when you're, treating a myelofibrosis patient, a good general rule of thumb is to maybe put them into one of these categories. And myelofibrosis, our goals of treatment in myelofibrosis are somewhat unique compared to other hematologic malignancies. Our focus at the present time is to reduce spleen size and improve symptoms. That's where the endpoints for most of our clinical trials lie. But a new emerging importance in myelofibrosis is to lessen anemia. And as Dr. Kelajian had spoken of, the JAK inhibitor ruxolitinib, for which we've had for over 10 years, can address quite nicely the spleen size reduction and improvement of symptoms, but unfortunately can worsen this third aspect of anemia. So there clearly is an area of need for JAK inhibitors that actually address all three issues in myelofibrosis. So at the present time, we have approved 4 JAK inhibitors, ruxolitinib, which has been approved for over 10 years for myelofibrosis, as well as polycythemia vera, fedratinib, which is approved for upfront myelofibrosis, and more recently, pacritinib and momelotinib, which are approved for myelofibrosis. Pacritinib is approved first line for platelets under 50 or second line in any patient, according to the FDA. And then momelotinib is approved first line for any anemic myelofibrosis patients. So each of the JAK inhibitors has a little bit of a different target profile, have some adverse events that are similar in a class effect, and some that are unique to each agent. And wanted to, on my slide said, I'm going to be focusing on pacritinib as well as momelotinib, and just wanted to bring your attention to the uniqueness of these two agents in terms of their ability to inhibit ACVR1, and then pacritinib also can inhibit IRAK1. So how to choose a JAK inhibitor? Because ruxolitinib has been around for quite a while, many current myelofibrosis patients are on ruxolitinib. But if one is starting with a fresh myelofibrosis patient in the era of having 4 JAK inhibitors available, one can really select an upfront JAK inhibitor that is tailored to the specific myelofibrosis patient. For ruxolitinib, patients who have an enlarged spleen and symptom burden yet have robust counts, ruxolitinib is a very good choice because it may also give you the benefits of some cytoreduction if that's what you're looking for. And in terms of cytopenic myelofibrosis patients, we have 2 options that one can think about, pacritinib and momelotinib. If a patient has platelets less than 50, upfront pacritinib is approved. Momelotinib is approved for patients who are anemic. And in terms of the patients who are anemic and thrombocytopenic at baseline with platelets less than 50, one can choose either pacritinib or momelotinib. And because many myelofibrosis patients who have had myelofibrosis for quite a while have been on ruxolitinib, because that's the only JAK inhibitor that was available up until recently, patients can have ruxolitinib quote failure or intolerance or progression on ruxolitinib. So what does that mean? What exactly does ruxolitinib failure look like? One can have primary resistance, where they really never responded to ruxolitinib in the first place, or secondary resistance, where they initially enjoyed a reduction in spleen size and improvement of symptoms, but over time they've lost that response and their spleen is growing and their symptoms are coming back. Can have intolerance, meaning they have some most likely a hematologic toxicity, such as cytopenias, or a non-hematologic toxicity. And then progression, specifically progression to looking like they're moving towards a leukemia. So this is a repeat slide, but wanted to emphasize how common anemia is in the myelofibrosis patient population. It's present in about 35 to 50% of patients with myelofibrosis at diagnosis. About half patients require at least 6 red blood cell transfusions per year, and is an independent prognostic risk factor for leukemia transformation. So it really is an important aspect of the disease and is telling in terms of prognostication. And MF patients can also have thrombocytopenia, but it's important to emphasize that usually the anemia and thrombocytopenia go together. It's quite unusual for somebody with myelofibrosis to have isolated thrombocytopenia, but not anemia. And again, the role of hepcidin, wanted to re-emphasize this, that the anemia in myelofibrosis is likely multifactorial, but elevated hepcidin, which is the mechanism of anemia of chronic inflammation, is also clearly playing a role in the anemia of myelofibrosis. And so that is potentially why momelotinib and pacritinib are potentially beneficial for anemia in myelofibrosis, where they block ACVR1, resulting in reduction of hepcidin and a subsequent increase in iron, hemoglobin, and erythropoiesis. So I wanted to emphasize this small clinical trial led by Steve O at Washington University that focused on trying to delve into the mechanism of hepcidin inhibition and anemia in myelofibrosis. So here anemia, the hepcidin levels can be quite variable among myelofibrosis patients. But here, just demonstrating that with the first momelotinib dose, could observe a reduction in serum hepcidin in patients, both in the responders as well as the non-responders in terms of hemoglobin response with momelotinib. And on the right is the hepcidin daily change throughout this 24-week clinical trial. And here is breaking down the patients into 2 categories, the responders or the non-responders, in terms of their improvement in hemoglobin. And interesting, as you can see, that the non-responders, the blue line, had higher baseline hepcidins compared to the responders. And then on the bottom is the change in hemoglobin. And then moving on to focusing on pacritinib, which just to sort of emphasize the uniqueness of pacritinib, It is a JAK2 inhibitor. It does not inhibit JAK1, which makes it a little bit different than the other JAK inhibitors. Inhibits ACVR1, similar to momelotinib. And a unique aspect of pacritinib is its IRAK1 inhibition. And IRAK1 is an important mediator of inflammatory signaling. So that also may play a role in pacritinib's benefit. There were two phase 3 pacritinib trials, PERSIST-1 and PERSIST-2. Major differences: PERSIST-1 had no prior, basically people had to be JAK2 inhibitor or JAK inhibitor naive, and PERSIST-2 patients could have a previous JAK inhibitor. And I wanted to emphasize that in PERSIST-1, no exclusion for baseline platelets, and in 2, platelets could be less than 100. And then in PERSIST-1, pacritinib versus best available therapy, but not ruxolitinib. And in PERSIST-2, had 2 dosing schedules of pacritinib, either 400 daily or 200 twice a day. They both had a total dose of 400 daily. And then versus best available therapy, including ruxolitinib. Both studies, the primary endpoint, week 24, greater than or equal to 35% spleen volume response, with a 50% reduction in TSS as a secondary endpoint in PERSIST-1 and a co-primary endpoint in PERSIST-2. And so then this is focusing on the PERSIST-2 data in the 200 twice a day cohort, demonstrating that 25% of the pacritinib arm had clinical improvements in hemoglobin compared to 12% of the best available therapy. And similarly, in 22% reduced transfusion burden in pacritinib versus 12% in best available therapy. And then here is transfusion independence among patients who are transfusion dependent at baseline, looking at 2 different criteria for transfusion independence: the Gale criteria, which is no red blood cell transfusions over 12 weeks, versus simplified criteria, which is no transfusions over 12 weeks and no hemoglobin less than 8. So with the pacritinib 200 BID arm, almost 40% became transfusion independent versus less than 10% of the best available therapy arm. And then with a more strict criteria of the simplified criteria, about 25% became transfusion independent versus, again, less than 10% in the best available therapy arm. Then moving on to a non-JAK inhibitor, we really focus on JAK inhibitors in myelofibrosis, but it isn't important to think outside of the JAK inhibitor box. Luspatercept is an interesting agent to utilize for anemia in myelofibrosis. It is a erythroid maturation agent and can be used to address anemia in other diseases. For example, for patients with MDS with ring sideroblasts. And interestingly, some myelofibrosis patients can also have coexisting SF3B1 mutations. So this might be particularly helpful for those patients. And so quickly wanted to focus on this luspatercept phase 2 study. In this study, there were 4 cohorts, which is a little bit confusing, but thinking about it as splitting people into whether or not they've had ruxolitinib, yes or no, and whether or not they have needed red blood cell transfusions, yes or no. So there's 4, that ends up with 4 groups. And we'll be focusing on the 2 cohorts, 2 and 3B, who were the patients who were red blood cell transfusion dependent. And so this study looked at or is looking at luspatercept and the response in terms of transfusion needs. Here's the data for the two cohorts who were transfusion dependent at baseline, and splitting them up onto whether they are ruxolitinib naive or have had ruxolitinib. That cohort 2 had 10% reduction in the need for red blood cells transfusions, whereas over a quarter of the patients in cohort 3B had a improvement in their need, or reduction in their need for transfusions. And then here's in the middle is entire treatment duration, whether they've had transfusion independence for at least 12 weeks. And then on the right is a reduction in the red blood cell transfusion needs over the entire duration. So therefore, luspatercept can be utilized as an add-on agent to potentially JAK inhibitors to potentially ameliorate the cytopenias seen if somebody's doing very well with ruxolitinib and doesn't necessarily want to change, but would rather add on an agent.